Hello everyone! Today we're going to talk about the coronavirus disease, specifically the COVID-19 and MERS-CoV. Coronaviruses are a large family of viruses that can infect both animals and humans. It was first identified in the mid-1960s. They are a respiratory virus named for their crown-like spikes on their surface. These viruses are culprits in several outbreaks across the globe. Usually, coronaviruses spread in animals but can jump to humans. From there, the pathogens can spread from person to person. Within the order of Nidovirales and the subfamily of Coronavirinae lies the family Coronaviridae. This is further specified into 4 genera, which is the alpha, beta, gamma, and delta coronaviruses, whereas alpha coronaviruses and beta coronaviruses exclusively infect mammalian species. Gamma coronaviruses and delta coronaviruses have a wider host range that includes avian species. There are 7 known types of human coronaviruses, wherein 4 types, namely 229E, NL63, OC43, HKU1, cause mild to moderate respiratory infections, such as the common cold. 2 types, however, cause severe respiratory infections, the SARS-CoV and the MERS-CoV. The 7th coronavirus type is the novel coronavirus, SARS-CoV-2, that has spread from China to the rest of the world. Next is the human coronavirus discoveries. In the year 1965, researchers at the Common Cold Research Unit in Wiltshire, UK, report cultivating a virus named B814 from a boy with a cold. They describe the pathogen as virtually unrelated to any other known virus of the human respiratory tract. In 1966, Dorothy Hamre and John Procknow of the University of Chicago describe a virus which they dubbed 229E, isolated from a medical student with a cold. It is distinct from other known respiratory viruses. In the year 1967, scientists at the National Institute of Allergy and Infectious Diseases report using the same methods used to culture B814 to grow another new human virus with a similar morphology. They named the virus OC43. In 1968, 8 researchers, including the discoverers of B814, 229E, and OC43, and June Almeida, who first imaged coronaviruses, write to Nature to propose that this and several other recently isolated human viruses belong to a new category, coronaviruses. These viruses, they say, have a characteristic fringe of projection 200 angstrom long, which are rounded or petal-shaped, recalling the solar corona. In 2003, an international group of researchers report that the outbreak of severe acute respiratory syndrome, or SARS, which began in late 2002 in southern China, is caused by a newly emerged human coronavirus. In 2004, researchers at Erasmus Medical Center in the Netherlands report isolating a coronavirus, later named NL63, from a child with pneumonia. In 2005, a group of researchers based at the University of Hong Kong discovers another coronavirus, HKU1, in samples from 2 patients with pneumonia. In 2012, researchers at Erasmus Medical Center and their colleagues identify a new coronavirus, later named MERS-CoV, that was isolated from a man in Saudi Arabia with pneumonia and kidney failure. In 2020, a team of researchers in China identified the cause of a disease outbreak in Wuhan as a novel coronavirus now known as SARS-CoV-2. MERS-CoV is a viral respiratory disease caused by a novel coronavirus that was first identified in Saudi Arabia in 2012. Most MERS patients develop severe respiratory illness with symptoms of fever, cough, and shortness of breath. A large MERS outbreak occurred in the Republic of South Korea, linked to a traveler from the Arabian Peninsula in 2015. Travel-associated cases have been identified in Algeria, Austria, China, Egypt, France, Germany, Greece, Italy, Malaysia, Netherlands, Philippines, Republic of Korea, Thailand, Tunisia, Turkey, United Kingdom, and the United States. The pathogenesis of the MERS-CoV. There might be an unknown reservoir in the transmission cycle of MERS-CoV. Bats play a role in the context of MERS-CoV transmission. The virus is transmitted through dromedary camels through an unknown mechanism. The dromedary camels act as amplifying hosts for the virus. MERS-CoV is transmitted from dromedary camels to humans through the respiratory aerosols and some other unknown mechanism. The virus is then transmitted among the human population through the respiratory routes. This leads to patient exposed to the virus itself, or live viral particles adhere to inanimate objects called fomites. Recipient touching infected fomite subsequently touches any of their mucous membranes, risks the exposure of the virus itself. When this virus spreads directly in mucous membranes through surrounding cells, which is the major mechanism, or virus enters the bloodstream. So once the virus enters the body, MERS-CoV first binds via its S proteins to the receptor TPP4 on the target cell, and then releases its RNA genome through plasma or endosomal membrane fusion into the target cell. After transcription and translation, the new genomic RNA and viral proteins are then assembled into virions, which are transported via vesicles and released from the host cell in a manner similar to SARS-CoV. The most common symptoms of MERS are fever, cough, and shortness of breath. People may also have gastrointestinal problems such as diarrhea, nausea, or vomiting. Pneumonia is a common complication. There have also been reports of organ failure linked with MERS, especially kidney failure. The symptoms usually appear 5 to 6 days after exposure to the virus, but they may take 2 to 14 days to arise. Some people transmit the virus without experiencing any symptoms, while some others with MERS experience minor symptoms. People at increased risk for MERS includes recent travelers from the Arabian Peninsula, close contact of an ill traveler from the Arabian Peninsula, close contact of a confirmed case of MERS, healthcare personnel not using recommended infection control precautions, and people with exposure to camels. The diagnostic and laboratory procedures. Number 1 is the polymerase chain reaction assay, a molecular test that can be used to detect viral RNA in clinical samples. CDC's current case definition for laboratory confirmation of MERS-CoV infection requires either a positive polymerase chain reaction result for at least 2 specific genomic targets, or a single positive target with sequencing of a second target. The PCR is performed on a sample of respiratory secretions or blood. Second is serology. It is used to detect previous infections in people who may have been exposed to the virus. Antibodies are proteins produced by the body's immune system to attack and kill viruses, bacteria, and other microbes during infection. The presence of antibodies to MERS-CoV indicates that a person had been previously infected with the virus and developed an immune response. Third is imaging tests. Other tests may be abnormal, but they are not specific for SARS or MERS. The chest X-ray shows pneumonia, which may look patchy at first. Typically, infiltrates may look like ground glass on CT scan, but may progress to a whiteout appearance. Medical management. Management of the Middle East Respiratory Syndrome coronavirus infection is supportive. This includes hydration, antipyretic, analgesics, respiratory support, and antibiotics if needed for bacterial superinfection. Number 1. Consultations. Upon suspicion of MERS, the patient should be placed in an airborne infection isolation room with a minimum of 12 air exchangers per hour, and personal protection equipment appropriate for contact and airborne precautions should be used. Number 2. Medical care. Medical care is supportive and depends on the severity of illness. Number 3. Prevention. No MERS-CoV vaccine is commercially available. Prevention of infection in areas where MERS-CoV is being actively transmitted requires avoidance of potentially infectious secretions and careful attention to hand and respiratory hygiene. Pharmacologic management. No medications have been approved for the treatment of coronavirus infections. Clinical trials are needed to establish any benefit from ribavirin and/or interferon alpha. Prevention. Avoid touching your eyes, nose, and mouth with unwashed hands. Cover your nose and mouth with a tissue when you cough or sneeze, then throw the tissue in the trash. Wash your hands often with soap and water for at least 20 seconds and help young children do the same. If soap and water are not available, use an alcohol-based hand sanitizer. Avoid personal contact such as kissing or sharing cups or eating utensils with sick people. Clean and disinfect frequently touched surfaces and objects such as doorknobs. Nursing assessment. Number 1. History. A high index of suspicion is necessary to suspect MERS, and a traveler and exposure is essential to the diagnosis. History of residence or travel in the Arabian Peninsula. Next is in countries where MERS-CoV is known to be circulating in dromedary camels. Next is where human infections have recently occurred and exposure within the incubation period of 14 days. Number 2. Physical exam. Clinical manifestation is indistinguishable from other common respiratory viruses and may range from no symptoms to rapidly progressive multi-organ failure and death. Nursing diagnosis. 1. Infection related to failure to avoid pathogen secondary to exposure to MERS-CoV. 2. Deficient knowledge related to unfamiliarity with disease transmission information. 3rd. Hyperthermia related to increased metabolic rate. 4th. Ineffective airway clearance related to excessive reduction of pulmonary secretions. 5th. Anxiety related to unknown etiology of the disease. Nursing management. Number 1. Monitor vital signs. Monitor the patient's temperature. The infection usually begins with a high temperature. Monitor the respiratory rate of the patient, as shortness of breath is another common symptom. Number 2. Educate the patient and folks. Include the patient and folks in creating the teaching plan, beginning with establishing objectives and goals for learning at the beginning of the session. Provide clear, thorough, and understandable explanation and demonstrations. And give information with the use of media. Use visual aids like diagrams, pictures, videotapes, audio tapes, and interactive internet websites. Number 3. Reduce increase in temperature. Adjust and monitor environmental factors like room temperature and bed linens as indicated. Encourage ample fluid intake by mouth. Eliminate excess clothing and covers and give antibiotic medications as prescribed. Number 4. Ensure patent airway. Teach the patient the proper ways of coughing and breathing. Position the patient upright if tolerated, and encourage patient to increase fluid intake to 3 liters per day within the limits of cardiac reserve and renal function. Number 5. Reduce anxiety. Use presence, touch, with permission, verbalization, and demeanor to remind patients that they are not alone and to encourage expression or clarification of needs, concerns, unknowns, and questions. Accept patients' defenses. Do not dare argue or debate. Converse using simple language and brief statements, and allow the patient to talk about anxious feelings and examine anxiety-provoking situations if they are identifiable. Prognosis. MERS is associated with a rapidly progressive severe respiratory illness, and mortality compared to the SARS-CoV outbreak of 2003 is very high. Since 2012, the MERS outbreak in Saudi Arabia has slowly continued, with a total of 933 individuals diagnosed with 401 deaths as of March 2015, for a mortality rate of about 50%. COVID-19 is a disease caused by a new strain of coronavirus. CO stands for corona, V for virus, and D for disease. Formerly, this disease was referred to as the 2019 novel coronavirus or 2019 nCoV. It can cause symptoms from common cold to more severe disease such as pneumonia, and eventually it may lead to death, especially those in vulnerable groups such as the elderly, the very young, and the people with an underlying chronic health condition. Early on, many of the patients in the outbreak in Wuhan, China, reportedly had some link to a large seafood and animal market, suggesting animal-to-person spread. However, a growing number of patients reportedly have not had exposure to animal markets, indicating person-to-person spread is occurring. Pathogenesis of SARS-CoV-2. This starts when respiratory droplet production by human host or animal vector infected with SARS-CoV-2. This then leads to droplet contact with mucous membrane of recipient, thereby causing exposure to the virus, or live viral particles adhere to inanimate objects called fomites, which leads to recipient touching infected fomite, subsequently touches any of their mucous membranes, cause exposure to the virus. The virus then spreads directly on mucous membranes to surrounding cells or enters the bloodstream. The life cycle of SARS-CoV-2 in the host cell. The S-glycoproteins of the virion bind to the cellular receptor angiotensin-converting enzyme 2 and enter the target cell through an endosomal pathway. Following the entry of this virus to the host cell, the viral RNA is unveiled in the cytoplasm. ORF1a and ORF1ab are translated to produce PP1A and PP1AB polyproteins, which are cleaved by the proteases of the RTC. During replication, RTC drives the production full-length negative RNA copies of the genome and used as templates for full-length positive RNA genomes. During transcription, a nested set of subgenomic RNAs is produced in a manner of discontinuous transcription. Even though these subgenomic RNAs may have several open reading frames, only the closest ORF will be translated. Following the production of SARS-CoV-2 structural proteins, nucleocapsids are assembled in the cytoplasm and followed by budding into the lumen of the endoplasmic reticulum, Golgi intermediate compartment. Virions are then released from the infected cell through exocytosis. People with COVID-19 have a wide range of symptoms reported, ranging from mild symptoms to severe illness. Symptoms may appear 2 to 14 days after exposure to the virus. People with these symptoms may have COVID-19, dry cough, fever, muscle or body aches, sore throat, shortness of breath, new loss of taste or smell, fatigue, runny nose, diarrhea, difficulty breathing in severe cases. Diagnosis. Viral tests are used to look for current infection. A viral test checks specimens from your nose or mouth to find out if you are currently infected with SARS-CoV-2. There are 2 types of viral tests that can be used. Number 1, nucleic acid amplification test. This detects the virus's genetic materials and are commonly used in laboratories. NATs are generally more accurate but sometimes take longer to process than other test types. Number 2, antigen test. This detects viral proteins and are generally not as sensitive as NATs, particularly if the antigen test is used in someone without COVID-19 symptoms. If you have a positive or negative antigen test, your healthcare provider may need to confirm the test result with a NAT. Next is antibody or serology test. This looks for antibodies in your blood to determine if you had a past infection with the virus that causes COVID-19. Antibodies are proteins created by your body's immune system soon after you have been infected or vaccinated. Antibodies help you fight off infections and can protect you from getting the disease again. How long this protection may last is different for each disease and each person. Antibody tests should not be used to diagnose a current infection with the virus that caused COVID-19, except in instances in which viral testing is delayed. An antibody test may not show if you have current infection because it can take 1 to 3 weeks after the infection for your body to make antibodies. Medical management. Number 1, hand hygiene. Wash hands often with soap and water for at least 20 seconds. If water and soap are not available, use an alcohol-based hand sanitizer. Number 2, keep hands off your face. Avoid touching the eyes, nose, and mouth with unwashed hands. Number 3. Maintain social distancing. Avoid close contact with people at least 3 feet or 1 meter who are sick, and stay at home when you are sick. Number 4. Proper cough and sneeze etiquette. Cover your cough or sneeze with a tissue, then throw the tissue in the trash. Number 5. Supportive care. People infected with COVID-19 should receive supportive care to help relieve symptoms. Number 6. Severe cases. For severe cases, treatment should include care to support vital organ functions. On October 22, 2020, the FDA approved its first COVID-19 treatment, the medication remdesivir Veklury. It's available by prescription for people ages 12 years and older who have been hospitalized. It's administered as an intravenous infusion. In November 2020, the FDA also granted EUAs to monoclonal antibody medication. Monoclonal antibodies are human-made proteins that help to fight off foreign-made substances such as viruses. These medications are bamlanivimab from Eli Lilly and casirivimab and mdivimab, which must be administered together from Regeneron Pharmaceuticals. Like remdesivir, they are also administered by IV infusion and intended for people ages 12 years and older. These medications are used for outpatient therapy. The FDA has also issued EUAs to a few other treatments, such as convalescent plasma, that are intended for people who are hospitalized or at high risk for hospitalization. How COVID-19 vaccines work. COVID-19 vaccines help our bodies develop immunity to the virus that causes COVID-19 without us having to get the illness. Different types of vaccines work in different ways to offer protection, but with all types of vaccine, the body is left with a supply of memory T lymphocytes as well as B lymphocytes that will remember how to fight the virus in the future. It typically takes a few weeks for the body to produce T lymphocytes and B lymphocytes after the vaccination. Therefore, it is possible that a person could be infected with the virus that causes COVID-19 just before or just after vaccination, and then get sick because the COVID vaccine did not have enough time to provide protection. Sometimes after vaccination, the process of building immunity can cause symptoms such as fever. These symptoms are normal and are signs that the body is building immunity. Types of vaccines. Number 1. mRNA vaccines. These contain material from the virus that causes COVID-19 that gives our cells instruction for how to make a harmless protein that is unique to the virus. After our cells make copies of the protein, they destroy the genetic material from the vaccine. Our bodies recognize that the protein should not be there and build T lymphocytes and B lymphocytes that will remember how to fight the virus that causes COVID-19 if we are infected in the future. Number 2. Protein subunit vaccines. These include harmless pieces of the virus that cause COVID-19 instead of the entire germ. Once vaccinated, our immune system recognizes that the proteins don't belong in the body and begins making T lymphocytes and antibodies. If we are infected in the future, memory cells will recognize and fight the virus. Number 3. Vector vaccines. These contain a weakened version of a live virus, a different virus than the one that causes COVID-19, that has the genetic material from the virus that causes COVID-19 inserted in it Once the viral vector is inside our cells, the genetic materials give cells instructions to make a protein that is unique to the virus that causes COVID-19. Using these instructions, our cells make copies of the protein. This prompts our bodies to build T lymphocytes and B lymphocytes that will remember how to fight that virus if we are infected in the future. Currently, 2 vaccines are authorized and recommended to prevent COVID-19. The first one is named BNT162b2, which is manufactured by Pfizer Incorporated and BioNTech. This is a mRNA type of vaccines and is given through IM, and 2 shots are given 21 days apart. It does not contain any eggs, preservatives, or latex. The most common side effects in the arm is pain, swelling, and redness, and throughout the rest of the body is chills, tiredness, and headache. The second vaccine is named mRNA 1273, which is manufactured by Moderna TX Incorporated and is a mRNA type of vaccine also, and is given 2 shots. However, it is 1 month apart or 20 days. It is given through shot in the muscle of the upper arm or intramuscular. It does not contain any eggs, preservatives, and latex also. The most common side effects is the same as well as stated before in the Pfizer vaccine. Nursing assessment. First is the travel history. Healthcare providers should obtain a detailed travel history for patients being evaluated with fever and acute respiratory illness. Next is the physical examination. Patients who have fever, cough, shortness of breath, and who has traveled to Wuhan, China recently must be placed under isolation immediately. Nursing diagnosis. Number 1. Infection related to failure to avoid pathogen secondary to exposure to COVID-19. Number 2. Deficient knowledge related to unfamiliarity with disease transmission information. Number 3. Hyperthermia related to increase in metabolic rate. Number 4. Impaired breathing pattern related to shortness of breath. Number 5. Anxiety related to unknown etiology of the disease. Nursing management. Number 1. Monitor vital signs. Monitor the patient's temperature. The infection usually begins with a high temperature. Monitor the respiratory rate of the patient, as shortness of breath is another common symptom. Number 2. Monitor oxygen saturation. Monitor the patient's oxygen saturation because respiratory compromise results in hypoxia. Number 3. Maintain respiratory isolation. Keep tissues at patient's bedside. Dispose secretions properly. Instruct the patient to cover mouth when coughing or sneezing. Use masks and advise those entering the room to wear masks as well. Place respiratory stickers on charts, linens, and so on. Number 4. Enforce strict hand hygiene. Teach the patient and folks to wash hands after coughing to reduce or prevent the transmission of the virus. Number 5. Manage hyperthermia. Use appropriate therapy for elevated temperature to maintain normothermia and reduce metabolic needs. Number 6. Educate the patient and folks. Provide information on disease transmission, diagnostic testing, disease process, complications, and protections from the virus. Globally, as of 7:49 p.m. Central European Time, January 30, 2021, there have been 101,561,250 219 confirmed cases of COVID-19, including 2,196,944 deaths reported to WHO. Prognosis. Although the risk factors for COVID-19 remain unclear, some risk factors put patients at a significantly higher risk of mortality, especially in individuals with underlying conditions. Some medical disorders are correlated with higher risk of mortality in COVID-19 patients. This include cardiovascular diseases with a mortality risk of 10.6%, lung disease with a mortality risk of 7.3%, type 1 and type 2 diabetes with a mortality risk of 6.3%. Immunosuppression, for example, cancer patients with a mortality risk of 5.6%, and age. COVID-19 mortality rates increase with advancing age and are especially high in those aged more than 60 years. Elevated inflammatory markers in response to tissue damage have been associated with higher mortality rates.